Hey y'all, welcome back to another video. So today we're going to be going over Virchow's triad, which is essentially the factors that lead to thrombosis. And there's three, hence triad. You have endothelial cell injury, abnormal blood flow, as well as hypercoagulability. So before we get into some pathologies or issues in the body that will lead to increased abnormal blood flow, hypercoagulability, endothelial cell injury, let's get into what these mean. Okay, so endothelial cell injury essentially is an exposure of the subendothelial collagen. It could be a massive, large area, or it can just be a small area where it's a couple of cells that'll allow von Willebrand factor to bind to that subendothelial collagen with factor VIII, leading to platelet activation, attachment, and activation. So, abnormal blood flow. You have two types, right? You have stasis, which is where the blood is stopping, right? And then you have turbulent. Turbulent is the opposite of laminar. Laminar flow is when the flow is going smoothly down the vessel, and most of the cells and proteins and molecules are within the center of that flow. And turbulent is opposite of that. Those cells and those molecules are crashing into the walls, and if you want to think about it, kind of like a water slide, where you have a lot of twists and turns and you're crashing into the walls, and then you finally go straight into the pool. So hypercoagulability is essentially increased viscosity of the blood. Viscosity has to do with decreasing the flow rate or the speed at which the blood travels through the vessels, right? And this can be due to an increased number of coagulation factors like in Trousseau syndrome. It releases tissue factor as well as factor VIII, and that's going to help the coagulation pathway commence. Or you can have increased substrates for coagulation, right? So you can have increased lipids, or also in Trousseau syndrome, they produce mucin. Phospholipids are a substrate for the coagulation pathway to also commence. But you can see in a disease like hemophilia how you have a factor deficiency, it would lead to blood thinning, right? So an increased viscosity equals hypercoagulability. In another video, I'll go over genetic thrombophilias, but today I'm going to go over what's related to Virchow's triad. Hope that's okay with y'all. You just gotta bear with me for a little bit longer for the genetic lecture. Some of these pathologies can be causing thrombosis via a few of these pathways or all of these pathways. So we're going to go over some similarities between them. Right, so for endothelial cell injury, one major one is vasculitis, or inflammation within the vessels. In an acute phase, it'll lead to reversible cell injury, cell swelling, membrane blooding, mitochondrial swelling. You can, if you want to learn more about that, go over my reversible cell injury video. I explain everything there. But yeah, if that inflammation is prolonged, it can actually undergo irreversible cell injury, which would lead to cell death via apoptosis or necrosis. So if those cells die, you can definitely believe that that subendothelial collagen is going to be exposed, right? All right, cool. So our number two for endothelial cell injury is going to be hypertension. Hypertension does cause a lot of stress on the vessel wall, on the endothelium specifically, and it's essentially due to an increased hydrostatic pressure, a severely increased hydrostatic pressure. So again, if you want to learn about the effects of cell stress, you can go check out the reversible cell injury, but let's move on to number three. Number three, and this is in common with abnormal blood flow, atherosclerosis. Now, atherosclerosis essentially starts out as endothelial cell injury, and after those cells are injured, in order to help rectify the problem, the body starts transporting lipids to that site of injury, and those lipids begin to accumulate. And that's where you get cholesterol and cholesterol clefts within atherosclerotic plaques, right? And atherosclerotic plaques often undergo fibrosis, right? As well as dystrophic calcification. And I also have a video on metastatic, the differences between dystrophic and metastatic calcification, so go check that out as well. 4, post-MI actually shares in common with abnormal blood flow. And the reason that is because the endothelium of the heart, which is the innermost layer, is actually the furthest away from the vascular supply. When you get an infarct of that area, it's actually called a watershed infarct. A watershed infarct is actually ischemia to the tissue that is furthest away from the main blood supply. So if you think about the left and the right coronary arteries, when they go from the epicardium, they dive down through the myocardium and reach the endothelium. So the furthest point from that ischemic event or thromboembolic event that leads to ischemia is going to be affected the worst, right? So your endothelium is going to be primarily affected in a post-MI state. Now, why does it cause abnormal blood flow? Post-MI state causes abnormal blood flow because usually it'll also affect that muscles depending on how severe it was, how severe the ischemia was, how prolonged it was. It'll usually affect the myocardium as well. And the myocardium is due to contractility, which leads to pumping of the blood throughout the body, right? And if it's responsible for pumping the blood and a lot of that myocardial tissue dies off, then you're going to have abnormal pumping within the left ventricle or the right ventricle, and it's going to lead to turbulent blood flow as well as stasis of blood. And you can even get thrombosis within the left ventricle after an MI because of how uncoordinated those muscular contractions are. So 2, we're going to go back to atherosclerosis. So atherosclerosis leads to turbulent blood flow. And why is that? Because it decreases the intraluminal vascular space, right? Remember what I said, laminar flow, it just wants to be a smooth ride with all the cells in the center, right? When you decrease that space even just a little bit, it no longer becomes laminar flow. It can be laminar before, it can be laminar afterward, but in that section, it's going to be turbulent. And that little bit of turbulence is just going to make the problem worse, right? It's going to form a clot and allow it to propagate, which is to grow and to spread, right? So atherosclerosis also causes abnormal. Number 3 for abnormal blood flow, we're going to talk about aneurysms. So aneurysms are outpouchings of the vessel wall, and it's essentially going to be the opposite of atherosclerosis. So atherosclerosis is a decrease in the intraluminal vessel space. Well, this is an increase in the intraluminal vessel space because it's an outpouching. So an aneurysm would usually lead to blood stasis, right? Stopping of the blood flow because there's more volume of blood to be held within the aneurysm than the previous vessel can supply, as well as pass on to the next part of the vessel, right? So an aneurysm actually kind of looks like this. And something indicative of aneurysms, as well as in vivo clot formation, are called lines of Zahn, right? I'm going to do different colors for this, because lines of Zahn are layers of red blood cells as well as fibrin and platelets. And when you see this in histology, you are going to know that that was an in vivo clot formation. So 4 is sickle cell anemia, And sickle cell anemia can essentially cause turbulence as well as blood stasis. So turbulence, let's just say, as a sickle shape, kind of like the crescent of a moon, instead of its normal round biconcave disc with that little pit for the oxygen. The sickle shapes can actually, under stress, under decreased oxygenation, they can aggregate with each other and form polymers. This could lead to vessel blockage, leading to blood stasis as well as ischemia. Often sickle cell patients get pain from that ischemia, and just their abnormal shape as well as that aggregation would lead to many of the other molecules bumping into the wall and attaching to that as well. So sickle cell anemia under abnormal blood flow. Now we're going to get into hypercoagulability. So the first thing, and it has to do with increased substrates for coagulation, is going to be hypercholesterolemia as well as hyperlipidemia. All right, I'm going to just put hypercholes. You know, I'm just going to do it all. / lipidemia. And as I said, it provides a substrate for the coagulation pathway. Okay, our second one, what we named earlier, or we mentioned earlier, is malignancy or Trousseau syndrome. Now we know malignancy is tied to cancer. Malignancy is essentially abnormal cells invading different tissue as well as entering the bloodstream and traveling to a distant site. That is more metastasis. It's in the same boat with malignancy. So, Trousseau syndrome. And if you remember before, I mentioned that Trousseau syndrome is the release of tissue factor, which is coagulation factor 3, as well as factor 8, which binds von Willebrand factor to bind subendothelial collagen, like we talked about, as well as mucin. And mucin is another one of those substrates for coagulation. It's a very fatty lipid substance. Number 3, we're going to talk about antiphospholipid syndrome. And please don't get too excited. This isn't a deep dive on antiphospholipid antibodies, otherwise known as lupus anticoagulant syndrome. And I got a quick question for you. You might have this question, and it's a great question to ask and or have, is why is it called lupus anticoagulant under hypercoagulability? Right, that's so weird, that's odd. I don't know what medicine and scientists do with naming stuff, but let me explain. So it's under hypercoagulability because usually folks with antiphospholipid antibodies, or I guess a severe or increased amount of these antiphospholipid antibodies, would lead to increased coagulation, increased blood clotting, as well as, or increased thrombosis, as well as embolization of those thrombi. I'm gonna do another video on embolization, the different types of emboli, how it relates to thrombosis, as well as a different video for antiphospholipid antibodies. But lupus anticoagulant actually has to do with its testing in a laboratory setting. So I don't know if you may have heard this, but antiphospholipid antibodies in vivo inside the body would form clots, right? It usually leads to deep venous thrombosis or recurrent miscarriages in women, which actually brings us to number 4, which is pregnancy. I'm gonna explain that a little bit later, but in vivo in the body, it causes increased clots. Lupus anticoagulant is the name because people with lupus usually present with antiphospholipid antibodies, and when they have those antibodies in vitro or in a laboratory setting, it actually shows prolonged bleeding time. So that's so weird, like in vivo, in vivo, it causes hypercoagulability, but in vitro, it causes anticoagulation. So just remember that, y'all. That's why it's called lupus anticoagulant. And don't get confused on that. These are the same thing. Antiphospholipid antibodies lead to lupus anticoagulant syndrome, even though it causes hypercoagulability. All right. So pregnancy. Usually, pregnant women will often present with antiphospholipid antibodies. Okay. So folks with lupus, as well as pregnant women, will and may present with antiphospholipid antibodies. But that's not the only reason why pregnant women or pregnancy is under hypercoagulability. So pregnant women have about a similar risk in all stages of, or all 3 trimesters for a risk for DVT. It's about similar for all 3 trimesters. But in the last trimester, the 3rd trimester, the pregnant mom begins to produce thrombin, fibrinogen, as well as plasminogen activator inhibitor, right? So they produce thrombin, fibrinogen, and PAI, or plasminogen activator inhibitor. So thrombin plays a key role in activating factors 5, factors 8, factors 11, and 13 in the coagulation pathway. Okay? 11 is the first step of the intrinsic pathway. 5 binds factor 10 in the common pathway and activates it. Factor 8 binds subendothelial collagen along with von Willebrand factor. And factor 13 actually helps with the polymerization of fibrin clots. Fibrinogen, once activated, becomes fibrin, can become fibrin clots. Fibrinogen breakdown leads to fibrin monomers. Fibrin clot breakdown leads to D-dimers. Fibrin monomers as well as D-dimers are elevated in a state of DIC, and we'll do a separate video or disseminated intravascular coagulopathy. But also, fibrinogen plays a key role in platelet aggregation. If you have a dysfunctional fibrinogen or no fibrinogen at all, platelets cannot aggregate. They can adhere, they can activate, but they cannot lead to aggregation. And that's going to severely decrease your ability to form a fibrin clot, hence no fibrinogen or dysfunctional fibrinogen. Lastly, plasminogen activator inhibitor. This is a normally synthesized molecule by all of us. Whenever we're undergoing thromboembolic events, healthcare workers will administer TPA, or tissue plasminogen activator, right? This TPA actually overrides or overwhelms the plasminogen activator inhibitor in order to cause anticoagulatory effects. All right, let me say that again. So this plasminogen activator inhibitor, normally synthesized by the body, and so is TPA. But when healthcare workers during thromboembolic events administer TPA, it is to overwhelm this plasminogen activator inhibitor first and then provide anticoagulatory effects on the body. But that's the end of the video, y'all. Hope this was very helpful. This was Virchow's triad of endothelial cell injury, abnormal blood flow, and hypercoagulability. Have a great day.